there, everybody. We're going to talk about a serious topic because colorectal cancer is no longer being discussed as simply an old person's disease. Increasingly, doctors are seeing cases appear in younger adults, often in people with no obvious family history, no major warning signs, and no expectation that something serious might have been developing beneath the surface. Why? Why is this happening? What role do lifestyle, stress, inflammation, diet, environment, and early screening play? And perhaps most importantly, what can we do to protect ourselves and those we love now, before we need to? Today's guest is a Dr. Avishek Kumar. He's a hematologist and an oncologist, and he works directly with patients facing some of the most serious diagnoses imaginable. But his expertise extends beyond traditional medicine. Dr. Kumar also serves the United States Air Force 482nd Fighter Wing as a lieutenant colonel and a flight surgeon in aerospace and medicine services. It's in environments where, wow, performance, resilience, precision, and human health are constantly pushed to the limits. So this conversation is going to go way beyond fear and headlines. We're talking about what the data's showing, the warning signs many people overlook, the realities of prevention and early detection, and also how modern life may be impacting people in ways they fail to recognize until it's too late. So whether you're someone who avoids doctors entirely, which I might not recommend, someone who is making better health decisions and wants to keep making better ones, or simply someone who's really paying attention and watching this growing conversation around cancer and chronic disease, this is going to be an important discussion. So tune in and say hello to Dr. Kumar.
It's a pleasure to be here, Diane. Thanks for having me, and thank you for that warm introduction.
Oh my gosh, you have such a fascinating background. You're still involved with the Air Force, and you are also in private practice, and you deal with very stressful situations. How do you bridge these two things in your life? Parallels.
There definitely are parallels. We deal with fighter pilots and military personnel who all operate in extreme environments, and we also deal with cancer patients. And oftentimes the analogy that I like to use, something that pilots often see, is cockpit warning lights. So if you do see something pop up while flying an aircraft, it's really important not to ignore it or just kind of brush it off, because later on that can spiral into an emergency. In cancer patients, both before diagnosis, during diagnosis, and after diagnosis, we run into similar problems where oftentimes there's, say, if someone's having blood in their stool, or they're suddenly losing weight, or all of a sudden their stool caliber has changed. Those are warning lights that really cannot be ignored. And so that's one of those things in terms of the preventative aspect that I always emphasize to my patients.
Now, if someone did, we'll say they're not on one of any of the major prescriptions right now, but they just naturally notice they're losing weight and they don't understand why. Is that always accompanied with, let's say, blood in the stools? Or like, where does someone know to begin their search to try to get to you?
Right, so that's a very important and valid point. We are our own proverbial canaries in our own coal mine. And so it's a matter of degree. If, let's say, you stuffed yourself over Thanksgiving and a couple of weeks later you lost some of those pounds, then that's okay, right? Or if you're on a fitness kick and you're eating really well and dieting and limiting your calories and you're losing weight on a kind of a gradual pace, then that's okay too. However, if all of a sudden your spouse points out that, oh honey, it looks like you've lost a bunch of weight and you step on a scale and you're down 30 pounds, that is not normal. And if that is paired with other warning type findings like blood in the stool or iron deficiency anemia, then that's of concern. And certainly the first step to start would be to go to your primary care doctor and have it investigated.
Mm-hmm. Now, a lot of us are reading in the news now about colorectal cancer and also pancreatic cancer. Both present very similarly as far as the weight loss and often, let's say vomiting or blood in the stools. You'll hear a lot of people identify the both. How does that root look for people if they're noticing any of those?
Well, Dan, the root of it, unfortunately, can be very, very nonspecific. Abdominal pain can be 100 different things. It can be because of acid reflux. It can be because of food that you might have eaten or overeaten the night before. It can be because you hit yourself against something while, I guess, brushing up against a table. So it can be a number of different things. The key thing is symptoms that persist and don't really go away. So that is what we really have to look out for. And you mentioned pancreatic cancer, you mentioned colon cancer. All these can usually present in a constellation of symptoms, particularly as they advance and progress. So going back to colon cancer in particular, if you do have any sort of change in stool caliber and it's persisting, that could be indicative that something is lodged in your colon or there's some sort of growth, or it could be something unrelated as well. The same holds true with blood in the stool. A lot of times it's just hemorrhoids, but it could be something more sinister. And that's why it's really important to have a really good relationship with your primary care physician and go and have it investigated rather than just assuming, oh, it's probably nothing. It's probably just hemorrhoids. It's probably that week-old food I had in the fridge that I just ate that's now causing a stomach ache, and have it investigated thoroughly.
Now, I'm curious, since we're talking about bowel movements and bodily functions, is there a correlation between constipation versus loose bowel movements, or is it all something someone should be paying attention to?
Anything out of the ordinary. We're really more interested in patterns rather than individual instances. So if you suddenly have some diarrhea or suddenly have some constipation, if it happens for a day or two and then normalizes, less of a concern. But if it's been happening for months, by all means, especially if it's age appropriate, or like many people, even I guess otherwise very responsible people who haven't gotten their colonoscopies, go and see your primary care doctor and get your colonoscopy arranged so somebody can actually go in there and take a look, because that would be the gold standard.
Now, I'm curious. Obviously, I'm sure you deal with a lot of patients coming in who are their own Google Docs and now they're Instagram docs. So they have followed some pattern that there was some advice that someone gave them on social media, and they're taking it as the gospel that we should take, let's say, more magnesium. Well, I know more people who take lots of magnesium and now all of a sudden are having, they're like, well, I have the loosest poops every day. I'm like, I have to watch out that I don't sneeze because I might poop. I'm like, well, maybe you ought to cut that magnesium down. Are you finding you're getting more people presenting to you that are saying, I don't know what's going on with my bowel movements, and it's something as simple as way too much magnesium?
We are seeing more and more phenomenons like that. You mentioned Google Docs and Instagram Docs. Now we're even seeing AI-powered patients who are going and looking things up. And there is a place for that. Doctors don't have all the answers. Lots of things out there, and the field is ever evolving. But it's always good to go and be seen by a medical professional just for reasons, I guess, similar to what you just mentioned. If you're taking too much magnesium, you're taking some other supplement, it could have side effects. And some of those side effects could include changes in your bowel movements as well.
Now, prevention. Prevention's not talked about way too often. So what would you recommend people do to try to prevent a visit to you other than for that colonoscopy that, is a good preventive test that someone could do? Or not preventive, let's call it diagnostic awareness.
Well, living a healthy lifestyle, people are always asking, is there some sort of a natural cure or remedy or things I can do? And my answer to that is always yes. There's always things you can do. Live a healthy lifestyle. Don't be excessively overweight. Try to exercise. Humans aren't meant to be sedentary. These days, we all sit at our computers and look at our phones, but in reality, in caveman times and even up to 100 years ago, the vast majority of people worked in physical labor. And that's one thing that's sorely lacking. We're seeing an increase in obesity. We're seeing people eat more and more processed foods. To the best of your ability, don't do that. Try to eat more natural and whole foods. Try to stay physically active. Don't become excessively overweight. That all plays a role. And then also, age-appropriate screenings. We cannot emphasize this enough. So for women, getting breast cancer screenings, getting cervical cancer screenings at age-appropriate intervals, for everybody getting colonoscopies now at the age of 45, because we're seeing that younger and younger people are developing colon cancer. And if you have any warning signs or symptoms that blood in your stool or sudden weight loss or strong family history, get it done even earlier. But all that can be coordinated by your primary care physician. It's incumbent upon...
Sorry, go ahead.
Yeah. It's incumbent upon each individual patient to be an advocate for themselves and just look out for warning signs and symptoms.
What do you think is causing that rise in colon cancer at a younger age? Do you think it's better diagnostics, just showing something earlier on developing? Or is it actually something else, or a cluster of factors?
Like most things in medicine, usually it's a combination. It's multifactorial. People, as I mentioned before, are eating more and more processed foods, particularly in Western countries. We have a preponderance towards being overweight and also being obese. It's almost like an epidemic. And then people are much more sedentary. We have machines that do our farming and our labor for us. And so we have a lot more kind of sitting around. Nothing wrong with sitting around. I enjoy it quite much. But it's important for us to kind of get up and be more active. So all of these things are contributory. And plus, there's probably other X factors. Things are in our environment, changes in the gut microbiome. But all these are being studied as years and decades go on. But yeah, those factors are certainly contributory.
I recently heard someone say, or I read it, I'm not sure, sitting is the new cigarette smoking. Now, cigarette smoking obviously isn't going anywhere, nor and vaping is, on the rise. But it's an interesting thought. I'd like your perspective, because obviously the colon has to get a little more crunched up with sitting or leaning forward at a computer. You're kind of squishing your internal, versus when you stand up or sit up straight or get up and take a walk. It's a whole different compression. Is that applicable in any way, or is it just a visual I'm imagining?
I mean, it's an interesting perspective. I'm not sure if it's directly applicable, but yeah, you do, by being more sedentary, I guess you're at increased risk for having weight gain, and basically your body isn't utilized in the way that it's supposed to be utilized. I'll give you an interesting example. If for astronauts who are up in space, they make them exercise because there's no gravity in space. And if they don't exercise, then they'll lose muscle mass, they'll lose weight. And if they stay up in space for long enough without exercising, without gravity, when they come back down to Earth, they could have been Arnold Schwarzenegger up in space. They're going to lose a lot of that muscle mass. So the same way, those of us who aren't astronauts, we're down here on Earth, if we spend most of our time sedentary, tapping away at a computer and then come home and watch Netflix, well, it's one of those things where we're really not designed to be like that. And the calories that we may be consuming may be well in excess of what we need, and that'll cause us to develop more centripetal fat. And that is a direct contributor to both colon cancer as well as other types of cancers as well.
Now, you mentioned aerospace and astronauts.
Yes.
And you work with the Air Force. And my godson just graduated as a Top Gun pilot. And I remember, a year ago, watching that F-35, which was this flight come down to the ground, and when you could hear it go by, that's a lot of force on the body.
It really is.
Body. What kind of correlations have you seen in, let's say, pilots and those kind of forces on the body with this is kind of a broad question, with what people do in everyday life where they create correlations that you observe? Anything?
Yeah, there's quite a bit, and there's ongoing longitudinal studies. The reason why flight surgeons exist, and they've been around since the 1980s or so with Dr. Theodore Lister, who's part of the Army Air Corps. Basically, we've been studying aviators and trying to make the aerospace environment more and more favorable for humans to be up there. If you think about it, all of us will fly, say, I live in New Jersey to Chicago, and the plane will land maybe 20 minutes late, maybe the Wi-Fi wasn't working, and we'll complain about it, but a minor miracle just took place. You're up at 36,000 feet, where humans really aren't supposed to be, and if that pressurized cabin suddenly depressurized, well, you die pretty quickly. First you go unconscious, and then afterwards you won't be able to breathe, and it's really completely unsuitable to humans, but through the years and years of study and I guess evaluation of flight surgeons all around the world, we've developed these amazing technologies that allow us to fly from New York Airport to Chicago very casually and not die in the process. So we're seeing a lot of that.
Wow. Okay, so I'm curious, what is your day like? How are your parallel lives going?
Well, it's a good question. So day to day, when I'm here in Edison, New Jersey, seeing patients, I'll get different types of cancer patients, different types of anemia, and we'll sit down with the patient and we'll come up with a treatment plan and we'll do our best to get it evaluated. In the Air Force, the vast majority of it, when we go to our drill weekends, I'm a reserve flight doctor, not a full-time flight doctor, but we do all do a little bit of active duty time as well. On a day-to-day drill weekend, a lot of it is seemingly mundane but very important paperwork, making sure that pilots are fit to fly, that their EKGs are behaving themselves, that they're not sick, they're not taking any kind of medication which would, say, make them pass out while doing a high G turn in their F-16, things like that. And then for bits of time, like last year I went to El Salvador and we went on a humanitarian mission. It was wonderful. We got to help the local people. We supported their local hospital. We treated a lot of patients. We brought technology from the United States that they hadn't seen and left some of it there with them, thereby assisting them. So that's a great component of it, doing the humanitarian missions. And on top of that, we also fly. It's a requirement for us to fly a certain number of hours. So earlier this year, I went to Davis Monthan and I flew around the F-16. An amazing experience, experiencing those G-forces on you and trying not to G-lock, which is passing out, and just, I guess, sharing the environment with the pilots, and thereby, by learning what they go through, enhancing the science, which allow us to go into space and overall improves the situation, the framework under which pilots operate.
Yeah, I have to say, I truly wish everyone in the world could experience standing on a runway in your headphones so you don't go deaf, and having an F-18 or an F-35 fly by you on whatever sonic speed that is. And you're looking up and you're saying, oh my gosh, this is a miracle. This is really...
Oh, it is pretty crazy.
So I'm curious, you are a hematologist as well as an oncologist. Interesting combo of expertise. And then you also mentioned anemia.
Yes.
So let's talk about anemia.
Sure.
What are causes of anemia? What should people be? Are there ways people can notice it? Like I used to hear people say, well, if you touch your fingernail and it doesn't get pink quickly again, you might be anemic. Is this true? Is this Instagram medicine?
Well, that's a really important and actually a broad question. So just going back to the initial point, so I am a hematologist. Most oncologists are also hematologists. The training pathway is the same. After we train in general medicine or internal medicine, we do a fellowship for 3 years. We're trained in hematology and oncology. And in terms of what is anemia, well, the human blood has got 3 things in it. You have white blood cells, they're the immune defenses, right? You have your platelets. If you have a wound or cut, they help you heal it so you don't bleed out if you cut yourself shaving. And then finally, you have your red blood cells. Deficiency in the red blood cells is called anemia. Probably wondering, who cares? What is the significance of the red blood cells? How do they help me? Well, every single time we breathe in oxygen, it goes into our lungs. And it can't just stay in the lungs. It's like fuel for your whole body, for your brain, your kidneys, your muscles. It's got to be circulated throughout the body. Now, how do you get the oxygen that you just breathed in circulating from your lungs to the rest of your body? The red blood cells are kind of like little taxi cabs, and they carry it all throughout your body. Now, if you don't have enough of these taxi cabs, then it's called anemia, right? You've got a shortage of red blood cells. And if you do have a shortage, well, that puts a lot of strain on your heart because your body figures, okay, well, I don't have enough taxi cabs. Let me pump the heart faster and harder. And so that's why if you're anemic, you're going to develop palpitations doing things that normal people who aren't anemic wouldn't. So if, God forbid, this building were to catch on fire and you have to sprint out and you're anemic, well, that would be really taxing on your body, whereas somebody who isn't anemic wouldn't quite feel that pressure.
That was a great description. That was very visual. Thank you. Thank you. What are root causes of anemia for people?
That is a very good question too, and it's rather nuanced. So if you have say a young woman, premenopausal, the number one cause is probably heavy menstrual bleeding. So those red blood cells, those taxicabs I told you about, they only live 90 days. So you have to continually regenerate them, and regenerate them again. However, if, let's say, you're not consuming enough iron or losing it by a menstrual flow, well, you don't have the raw materials to build these red blood cells. And so persistently, you're building up less and less of them, right? So you're building less than you're losing, and that will gradually make you anemic, right? So that's a major cause, heavy menstrual bleeding in people who are vegetarians. Sometimes they don't take in enough iron, and so that might lead to iron deficiency anemia as well. In other cases, let's say you have a colon cancer and you have something physically growing inside your colon, well, that can result in anemia as well because you're bleeding out and you're also not absorbing iron very well because of that cancer.
Okay, so I have a curiosity question. I'm not a fan of putting things into my body, but I let
Hmm.
any doctor take all the blood they want when they want to check. If I went for a physical, go ahead, take all the blood. Let me know what it looks like. I'm a big believer in blood work and blood tests, and
Uh-huh.
I have years of it, every 3 months or so I, can compare things. But I'm curious in your professional opinion. You said blood cells can't last 90 days. So, is there a period of time someone said, I'm going to totally change my lifestyle? And I believe our blood is essential, our best predictor of what's going on in our body and our health. And
Uh-huh.
you can correct me, you're the hematologist, not me. But is there a period of time you could say, I'm going to do a healthier diet, work out, do all these things, and if every 90 days my blood cells, there's gazillions of them, are slowly dying off and new ones are getting created, could you regenerate your blood cell line?
Well, so it's not like all of them are on the same 90-day cycle. So
Right.
yeah, if you pictured each cell, and let's say just to simplify it and provide a visual image, so some will say day 1, some will say day 45, some will say day 89, and so they're all in different cycles. But I believe that if you wanted to rejuvenate yourself and adopt a healthy lifestyle, it actually goes hand in hand with limiting anemia because if you're not anemic, you'll be able to run better, you'll be able to lift weights better, you'll be able to function better. And the same holds true with the underlying iron by repleting your iron, by keeping it at healthy levels, whether it's through consuming more iron or getting a IV iron infusion or taking pills or whatever else, you kind of support your whole body's process. And if you're anemic, it's kind of like running a car on old oil. You can still do it, but if the car breaks down and there's smoke coming out of the hood on the side of the highway, that's just a risk that you're taking.
How are there parallels between anemia and colorectal cancer?
Oh, definitely. They're highly correlated. As a matter of fact, if you are a male and let's say you're feeling excessively tired and you go see your primary doctor and they do a workup and they find any evidence of anemia, particularly iron deficiency anemia, even if you're in your 30s or 40s, oftentimes colon cancer is a diagnosis of exclusion. You have to rule out colon cancer because certainly if you have a mass growing in your colon, in any part of the colon, can partially impair your absorption. It can cause bleeding. Unlike women, you don't have the menstrual issue to kind of contend with. And so you always have to rule out the possibility of the underlying colon cancer. Now, most of the time, mind you, when you do the colonoscopy at the recommended age of 45, you don't find a colon cancer. You might find some sort of irritation. You might find polyps. You may not find any sort of cancer, but it really gives you peace of mind. And that's why we're really pushing patients to go and get the age-appropriate screening at the age of 45, even if they don't have any symptoms.
Why do you think people resist that?
Gee, it's one of those sad facts of life where otherwise wonderful citizens, people who pay their taxes, they take care of their family, standing citizens, they go to religious places, they just function perfectly well. They just neglect spending time on themselves because they figure, well, I've got to take care of my kids or my job is getting busy or hectic. Years go by. They may be 45. They figure, okay, I'll do it later on. They turn 46, turn 47, and just don't do it. The issue is that if you do have some sort of an underlying colon cancer that's growing, then it's going to continue to grow. And if you catch it early, you can cut it out and effectively cure it, sometimes without even using any sort of chemotherapy if it's lymph node negative. But if you catch it later, even with all the wonderful advancements that we have in chemotherapy, targeted therapy, everything else, in 2026, once the cancer goes metastatic, once it leaves your colon, it goes to other parts of the body, most of the time it isn't curable. We can still treat it, we can still extend people's lives, but oftentimes we can't get rid of it altogether. That's why we implore people, go and get screened, because the screening can really save your life and save you a lot of trouble later.
What are some other things you'd recommend people do? Get a screening? Are there certain kind of other tests they should request? Blood panels? What do you recommend if someone came to see you?
Right. So actually, in my case, most of the time they come and see me after they've already been diagnosed with the cancer, right? I would recommend, and I love to harp on the fact that everyone should have a good primary care doctor that they're on good terms with, that they know, and they're really comfortable with, because they're really the gatekeepers, right? In this I guess, modern healthcare environment in the United States, oftentimes you're gonna, I mean, you might even skip your primary care physician visit, but you might just have a few minutes with them, right? But I encourage people to kind of come with a list of any sort of questions or concerns that they have and make sure to advocate for themselves, to make sure that that screening gets done. It's not your job to make sure that you're, I mean, I guess it's a shared responsibility to make sure that your health is good. But if you have any sort of unusual concerns or questions, don't be shy to tell the primary care doctor that, look, I've been having changes in my bowel habits. It's been this way for for several months, or my wife or my husband has noticed that I've been losing weight. Bring this up, and the primary care doctor should be taking the lead on saying, oh, you know what, let's get some basic blood work. And if anything turns up unusual in that, then follow it up further, right? Get the screening colonoscopy. Do whatever it takes, directed by the primary care doctor.
You said people usually come to you when they are already diagnosed.
Yes.
Could they see you earlier? Does your kind of practice allow for that? Is this something where someone could say, you know, I'm concerned with these things. I want to meet with an oncologist.
They can. They can. The vast majority of nonspecific symptoms aren't cancer at all. But in certain instances, that back pain that's been persisting might be some sort of a metastatic tumor that has spread from the breast to the spine. So that sort of thing happens. And sometimes we're called on board for hospital consultations. Let's say a patient has been throwing up for several days or been coughing for a while. And or in some cases, let's say they got into a minor fender bender, and then you got a X-ray of their arm, and on the corner of that X-ray, you notice some sort of a weird growth in the lung. Well, then they'll consult us, right? Even if the diagnosis hasn't formally been made. But just the way that the modern healthcare environment is, and kind of the shortage of different specialists, generally we get it worked up earlier on by, say, primary care doctors, by a pulmonologist, by gastroenterologists. And then once the diagnosis of the cancer is made, then they come and see me for management. And then I don't work in a silo or an island either. I'll work with surgeons, I'll work with radiation oncologists, I'll work with pulmonologists. And it's really like a team of different specialists, and we all work together with the common goal of getting rid of the cancer, or at least suppressing it, or managing it with medication or surgery or radiation or whatever it takes.
Now, if we were going to tell people 5 things between diet, exercise, and medical care, 5 to 10 things that you would recommend everybody thinks about on a daily basis or a monthly basis.
5 things. Okay. So I would say, all right, eat well, right? Keep a healthy diet. And that's 1, right? Number 2, exercise, right? And number 3, don't get obese. Number 4, see your primary care physician. Know them by name. Don't keep rotating. Try to keep the same one if you can. I realize that sometimes doctors retire or appointments aren't available, but ideally try to keep it consistent. And number 5, age-appropriate screening. That cannot be underemphasized. There are guidelines, and your primary care physician should keep you apprised of them. But breast cancer screening, colon cancer screening, cervical cancer screening, even lung cancer screening if you're a heavy smoker, all these things have been medically proven through study after study to help reduce mortality and save lives.
Did we miss anything? I'm sure we missed a lot, but what else would you want someone to know that maybe I didn't ask you?
Well, be your own advocate. If you have any sort of warning signs or symptoms, even if your visit to your physician is condensed to 7 minutes because they're running late, or you're running late, or paperwork, or whatever else, if you have something, speak up. Don't be shy. It's your right. And in case you forget, call them and have a conversation with your physician. Even if you can't get an appointment, if you've been established as a patient, call and say, hey, this has been concerning. Should something be done about it? Should it be worked up further? And what do you think about this? And I think that's really, really important, because many of the times, cancers that later on become stage 4 or metastatic, they start out as smaller concerns or issues that, if they're addressed early on, if the cancer is diagnosed early on, then potentially the cancers are curable, or at least highly treatable, whereas later on, when they're metastatic, it becomes a lot more difficult.
You mentioned being your own best advocate.
Yes.
I think that's fantastic advice. When you have someone, and you triggered another question, when you have someone being their own best advocate, how often do they come in with that Google information or chat or Perplexity or something and Do you have to sit down and say, well, we could look at it this way, but let's also look at it the way I've been trained and what I know and what I've seen throughout the course of my career?
Look, Western medicine doesn't have all the answers. As a matter of fact, one of the types of chemotherapy that we use comes from the bark of the yew tree, and it's synthesized from a natural product. And so many other things in medicine are the same way. So if somebody comes in with a stack of pages that they got from Google or from AI or Instagram, take your pick, I'll never blow it off. I'll say, okay, well, that looks interesting. Let's talk about it in a little more detail. Let's extract the nuance out of it. Let's try to figure out exactly what this means and how it's applicable in your situation. Because this magic pill that you saw on Instagram may not be applicable in your particular type of cancer. It may work great in a different type of cancer, but perhaps not yours. And that's why it's important for doctors, particularly in this era, not to just dismiss when somebody walks in with a bunch of papers. I mean, I'm sure that a lot of it has got a fair amount of validity. So we always try to respect it and try to talk about it and have a conversation, a dialogue.
You are fantastic. If I need a doctor, I'm going to Edison, New Jersey. I'm going to find you. Thank you so much. I have been speaking with Dr. Avishek Kumar. He's an MD, oncologist, hematologist, super informed guy, and also lieutenant colonel in the United States Air Force, dealing with our fighter pilots. So thank you for everything. I'm Diane Gorsell. I am the host of the Silver Dispedience Perception Dynamics podcast. I want you to follow Dr. Kumar. You'll be able to find links to his website here in case somebody needs to follow him. For any reason whatsoever, I suggest you do. And share this. There was a lot of good information he shared for yourself and your loved ones. So we're going to move over to the green room, Doctor. Thank you.
Pleasure. Thank you so much, Dan.
Thank you, everybody. Hit subscribe. Click all the links below. See you soon.